All right, I'd like to welcome everyone to this webinar. We'd like to thank the AUA for the opportunity to present on two topics. One will be the detection of prostate cancer, and secondly, the unmet need in renal cancer imaging. With us today, we have Dr. Jaydeep Sohi, who is president of American Molecular Imaging. He's also fellowship trained in PET-CT, and he will be discussing gallium-68 PSMA-11 PET-CT imaging for the detection of suspected metastatic or recurrent prostate cancer. So, Dr. Sohi, welcome and take it away.
Thank you, Esteban. It's a pleasure and an honor to be here today. My name is Jaydeep Sohi. As Esteban mentioned, I'm a nuclear medicine physician, and I'm here on behalf of Telix as a paid consultant. We will talk about two imaging agents, the first being Illuccix, which is a gallium-68 PSMA PET imaging agent for men with prostate carcinoma. Indications for this imaging agent include patients with suspected metastases who are candidates for initial definitive therapy, patients with suspected recurrence based on elevated PSA levels, and finally, those patients with metastatic prostate carcinoma for whom lutetium-based therapy, PSMA therapy, is indicated. With regards to safety of this imaging agent, based on studies, there has been a less than 1% adverse reaction rate, most commonly including nausea, diarrhea, and dizziness. A key point regarding drug interactions, ADT therapy, and other therapies that target the androgen pathway may result in changes in uptake of gallium-68 in prostate cancer. The effect of these therapies on performance of gallium-68 Gozellix PET has not yet been established. Now we'll talk about Gozellix, which is the newest gallium-based PSMA PET imaging agent for patients with prostate carcinoma. The indications for this new agent include patients with suspected metastases who are candidates for initial definitive therapy, as well as those with suspected recurrence based on elevated serum PSA levels. There are radiation risks associated with PET imaging. Every scan may contribute to a patient's overall long-term cumulative radiation exposure. Just like with Illuccix, the adverse reaction rate is very low, of less than 1%, and most common reactions were noted to be nausea, diarrhea, and dizziness. Just like with Illuccix, the role of ADT and other therapies that target the androgen pathway may have potential impact in changes in uptake of the tracer in prostate cancer, and the effect of these therapies has not yet been fully established. Gozellix has the longest time to dose expiration or shelf life of any gallium-68 based PET imaging agent that incorporates cyclotron-based gallium imaging. Gozellix can be produced via generator or cyclotron, which leads to increased supply and wider distribution of this tracer. Now let's talk about PSMA, or prostate-specific membrane antigen. PSMA is a transmembrane antigen that is overexpressed by a factor of 100 to 1,000 times in 95% of patients with prostate carcinoma. This is found to be more sensitive in detection of prostate carcinoma lesions, especially when the PSA is less than 1 nanogram per milliliter when compared to conventional imaging, which includes CT imaging and bone scan. The degree of PSMA expression positively correlates with tumor stage, high risk of recurrence, advanced stages, and generally poor prognosis. This slide demonstrates the indication of Illuccix across various stages of prostate cancer. Starting on the left of the screen, current indication is initial staging in patients with unfavorable intermediate, high risk, or very high risk prostate carcinoma prior to definitive therapy. The second indication is going to be patients who have undergone definitive therapy and now are known to be in biochemical recurrence. And finally, the newest indication is patients who are in metastatic castrate-resistant prostate carcinoma who are candidates for radioligand therapy. Let's talk about normal biodistribution of PSMA PET imaging agents. The image on the right of the screen demonstrates a normal gallium-68 PSMA scan. There's really no appreciable uptake in the brain, given that we're not using a tracer that deploys glucose metabolism. You'll notice that there's prominent uptake in the salivary glands, which include the lacrimal, parotid, and submandibular glands. There's no appreciable uptake within the chest in a normal gallium-68 PSMA imaging exam. The liver, spleen demonstrate mild to moderate tracer accumulation. Because of renal excretion, you notice there's prominent uptake within the kidneys. And finally, the excretion into the bladder. Let's talk about conventional imaging versus PSMA PET. Study comparing gallium PSMA with other imaging modalities shows the benefits of using gallium. 85% sensitivity versus 38% for conventional imaging. Superior specificity of 98% compared with 91% for conventional imaging modalities. And finally, 92% accuracy when compared to 65% for conventional imaging studies. Let's talk about false positives, especially in the bones. So given that pre-F18 may have a higher propensity of going to the bones, it may induce some uncertainty when it comes to resolving findings in the bones, whether they are benign or metastatic. And calling benign lesions as metastatic may have far-reaching implications for patients. Okay, let's talk about some clinical trial data for Illuccix and Gozellix. Let's talk about quality of imaging and the performance of gallium-68 PSMA-11 at low PSA levels. So here, a study that demonstrated 210 evaluable patients. True positive rate was 91%. The slide in the middle is very important. You can see that even at PSA as low as 0.25 nanograms per milliliter, there's almost 45% PET positivity ratio, and that value increases with the increasing PSA levels. True negatives, high specificity rate of 90% is also demonstrated with Illuccix. Speaking of high diagnostic value, here's a case with a patient with prostate carcinoma who underwent gallium-68 PSMA-11 imaging with a PSA of as low as 0.10. You can see that image on the left is the coronal PET image. In the middle of the screen are fused PET-CT and PET image in the axial projection. And finally on the right is the, again, coronal PET and fused PET-CT. Image A, if you look at the axial image, you can see there's focal intense uptake in the prostate bed, which is consistent with recurrence. And on the right is a small left obturator lymph node that demonstrates focal uptake. So even with a very low PSA, you're able to demonstrate findings in the prostate bed as well as nodal metastases. The next case is a 69-year-old male with new diagnosis of prostate carcinoma, Gleason 4+5, PSA of 21. A gallium-68 PSMA PET scan was formed, and you have fused PET-CT images in the axial, coronal, and sagittal planes. You can notice that there is intense uptake within the prostate gland, which is the primary malignancy, as well as uptake in the lower lumbar spine that demonstrates bony metastases. Same patient, we now zoomed into the exam, and you can see again on the left is the primary malignancy, and on the right is the solitary bony metastasis in the lower lumbar spine. Next case is 65-year-old male, 6 years post-prostatectomy, now with rising PSA levels. A gallium-68 PSMA-11 scan was performed. And now in this exam, you could see axial fused PET-CT at the top, MRI at the bottom, and on the right is a maximum intensity projection image. And you can see that there is a small focus of increased uptake in the sacrum. Once we enhance the image, you can see there's a small lymph node that's in the presacral area, which demonstrates nodal metastases in the presacral region. Next case, 60-year-old male, 1 year post initial diagnosis of prostate carcinoma, has had ADT as well as chemotherapy. Now comes for imaging with gallium-68 PSMA PET-CT study. And here you can see on the top there are multiple sclerotic lesions that do not demonstrate increased uptake, which are consistent with previously treated metastatic disease. The lower row demonstrates at least one lesion in the right acetabulum that demonstrates intense tracer uptake and is consistent with recurrent malignancy. So we're able to demonstrate both previously treated disease as well as active metastatic disease on this exam. Same exam, zoomed in study, you can see there's focal increased uptake in the right acetabulum. Next study, 77-year-old male with history of prostate adenocarcinoma has had prostatectomy, chemotherapy, as well as hormonal therapy, rising PSA levels. Gallium-68 Illuccix PET scan was performed for restaging prior to potential radioligand therapy. And here you could see multiple areas of focal uptake in the bony structures, including the thoracic spine on the top row, as well as the pelvis and the thoracic spine or lower cervical spine on the image at the bottom. So the patient does have osseous metastatic disease at presentation. Same exam, enhanced images, and you can see here there are multiple foci of increased uptake within the axial spine consistent with metastatic disease. This is an interesting case of patient with history of prostate carcinoma that demonstrates an isolated distant metastatic disease. The middle row demonstrates the finding the best, which is the PET in axial, sagittal, and coronal projections. And you can see there's an isolated PSMA-avid lesion in the lower cervical spine with intense PSMA expression. This is metastatic disease within the cervical spine. Additional views of the same findings. Intense tracer accumulation is seen in the lower cervical spine consistent with metastatic disease. 58-year-old male, history of prostate carcinoma, has had prostatectomy, rising PSA levels, gallium-68 PSMA PET scan was acquired. This case demonstrates small focus of increased uptake in the left pubic symphysis, which is consistent with metastatic disease. Same patient, another projection, additional focus of intense tracer uptake in the right iliac bone, also consistent with metastatic disease. So this case demonstrates the value of gallium-68 PSMA PET scan in patients with low but rising PSA levels. Okay, now we're going to switch to Gozellix, which is the gallium-68 PSMA-11 PET scan, recently approved for clinical use. This is a case of 68-year-old male, newly diagnosed prostate carcinoma with Gleason 7/8. Gozellix gallium-68 PSMA PET scan was performed for initial staging. And here, let's first show you the screenshots. The most important finding here is that patient does have focal intense uptake within the right aspect of the prostate gland, which is the primary malignancy, and additional focus of intense uptake at the apex of the prostate gland. There was no evidence for PSMA-avid lymph nodes within the retroperitoneal pelvic regions. And now let's see if we can switch to our dynamic viewer. So the first image that we're looking at is the maximum intensity projection image, or MIP. And here you could appreciate two foci of increased tracer uptake immediately inferior to the urinary bladder, which represent the findings that we discussed just previously. And as mentioned, there's no evidence for PSMA-avid nodal metastatic disease in the retroperitoneal pelvic regions. Now we could review the same study from skull vertex to the mid-thighs. And as we mentioned previously, there's no appreciable uptake within the brain, given that we're not deploying a tracer that is utilizing glucose metabolism. Uptake in the face and head and neck is prominent but physiologic. We're looking at fused PET-CT images in the axial projection currently. As we make our way into the lower neck, mild patchy uptake in the vocal cord is considered to be physiological. No appreciable tracer uptake is seen within the thorax. Patchy heterogeneous uptake in the liver, as well as prominent uptake in the spleen, is physiologic and normal. Prominent uptake is noticed in the bowel, small bowel, also a normal variant. We're looking carefully at the retroperitoneum and not noticing any evidence for tracer-avid lymph nodes. Prominent renal uptake of the tracer physiological in nature. And as we make our way inferiorly, again, no evidence for PSMA-avid lymph nodes in the iliac chain pelvic regions. Urinary bladder, that's accumulation of radioactive urine. And finally, we get to the prostate gland. And again, we can notice the primary lesion in the right aspect of the gland, as well as additional focus of intense uptake at the apex of the gland, demonstrating an additional focus of malignancy. Next case is a 55-year-old male with metastatic castration-resistant prostate carcinoma, has undergone 4 cycles of Pluvicto therapy, now comes with rising PSA levels with suspicion of progression of disease. Patient undergoes imaging with Gozellix 7 millicurie injection at 60-minute uptake time. And in this particular case, you could see the MIP image demonstrates numerous foci of intense uptake throughout the bony structures, including the shoulders, axial spine, and pelvis, which is consistent with extensive metastatic disease. Next image is the fused PET-CT images in the sagittal projection, and you can appreciate numerous lesions within the axial spine as well as the spinous process of the axial spine that demonstrate intense tracer accumulation consistent with active metastatic disease. Same patient, different projections. Now we have axial views of CT and PET-CT. The bottom row demonstrates intense tracer uptake in the axial spine, left shoulder, as well as the pelvis, osseous pelvis. And there's also at least one area of soft tissue uptake in the left anterior pelvis, which likely represents nodal metastatic disease. So this patient has evidence of osseous and possible nodal metastatic disease on the Gozellix gallium-68 PSMA PET imaging study. So let's put it all together. Global guidelines that recognize and recommend gallium-68 PSMA 11 PET-CT imaging include the Society of Nuclear Medicine and Molecular Imaging, the European Association of Nuclear Medicine, the NCCN, AUA, as well as the SUO. For Lucix, the guidelines include initial staging for suspected metastases, patients with biochemical recurrence based on elevated PSA, patients with non-metastatic castration-resistant prostate carcinoma with elevated PSA, and finally, patients who may be eligible for PSMA-guided radioligand therapy. Again, to summarize this, enhanced clinical accuracy with the ability to pinpoint micrometastatic disease at the earliest signs in a broad range of patients, with the possibility of acquiring high-quality images, reliable distribution network of more than 200 radiopharmacies with flexible scheduling, as well as end-to-end support. Gallium-68 PSMA-11 is widely available with nationwide distribution network of more than 220 generators and cyclotrons, as depicted on this map, which includes those within major academic centers, as well as community health systems. And with that, I thank you. Thank you so much for being here today.
Thank you, Dr. Sohi, for your presentation on PSMA PET-CT imaging of prostate cancer. Right now, we'd like to segue to renal cancer. As there seems to be an unmet need in advanced imaging of renal cancers, I'd like to invite Dr. Dan Joyce, who is assistant professor in the Department of Urology at Vanderbilt in Nashville. He has a keen interest in renal cancers and is going to really discuss the future of kidney cancer detection.
Thanks so much, Esteban. It's a pleasure to be with you guys talking about the CA9 imaging here, girentuximab, and its use in kidney cancer. The purpose of this is really educational. I am a paid consultant of Telix giving this talk. However, my goal here is just to inform you all of what the data are surrounding this novel imaging. So let's get into what renal masses are, what that means. You know, the vast majority of these masses are either cystic or solid, and by far, they're usually solid. When we see a solid mass, we know that 90% of the time, on average, they are malignant, meaning they're a renal cell carcinoma. And of course, the most common type of renal cell carcinoma is clear cell renal cell carcinoma, which comprises about 75% of those malignancies. There are, of course, other subtypes, papillary RCC, chromophobe, and then benign etiologies as well, including oncocytomas and angiomyolipomas. But again, when we talk about renal masses, clear cell renal carcinoma is usually what we're talking about. And when we see these masses, of course, we don't know what that is up front. And what we often are met with is this dilemma of an indeterminate renal mass. And that's basically anything we see in a kidney on a CT scan, MRI, or PET scan that we can't really tell what it is, malignant or benign. And we know that this is common. Overall, it's about 20% of the masses that we see on these scans, and that is more common when they're smaller. So they're harder to parse out when they are smaller, especially in that less than 2 centimeter range. The kidney cancer patient journey is worth looking at because it's changed over the past 50 years or so with the onset of CT scans. There has been a sharp increase in the use of cross-sectional imaging with CT scans over that time period. There was one study that looked at Medicare patients and found that 43% had gotten a CT for something within a 5-year period. And naturally, when you go looking for something, you find things. And often you find things that you didn't anticipate finding. And so with that increased use of imaging, we're seeing a lot more of these incidentally found renal masses. And the problem with that is that once we as physicians see an incidental renal mass, we often feel the pressure to treat it, as do patients. They don't like seeing something on a CT scan. They want it taken care of. And of course, as we find more, we're finding them earlier. So when we find these things, they often are these small renal masses, less than 4 centimeters, that are so hard to parse out whether they're malignant or benign. Most of these patients with these small renal masses are going to be referred to somebody like me, a urologist. Once they've seen the urologist, odds are that we're probably going to repeat an image because what they got first probably wasn't good enough to fully characterize their mass. Usually that's if we can give them contrast with and without a CT scan, although sometimes it's an MRI if we're seeing a cystic mass. And at that point, it really becomes a conundrum of what to do. And the way we as urologists deal with that is highly variable.
So Dr. Joyce, a question for you. As you're mentioning that a lot of these renal masses are found incidentally because of some other reason, and they've gotten some type of imaging and you see something, compare that to the number of patients that may be referred to you or come to see you because they're having symptoms that might be flank pain, hypertension, peripheral edema, things like that. What would be the comparison?
It's really, really rare nowadays that I see a patient with a small renal mass who's symptomatic from it. There is the occasional patient who has a deep invasion of the mass into their collecting system, despite it being small, might have some hematuria, microscopic hematuria with that sometimes. So it does happen, but it's honestly really rare. The vast majority of these are patients who really just happened to find it when they were looking for something else. They're having vague abdominal pain. That's probably not from their renal mass, and they end up catching it on a CT scan that gets done for a workup for that.
Right. Thank you for that.
So, I mentioned the variable management of what we as urologists do with these masses, and this is kind of the spectrum of what a patient might get. And so we can do one of four things. We can say, okay, before we deal with it, let's figure out what it is. Let's get a biopsy. The other option is to treat it. We could either freeze it or kill it with either hot or cold treatments. Usually what we do here at Vanderbilt is cryoablation, so freezing. And then surgery, cut it out. I could cut it out and then leave the kidney behind if it's amenable to that. There is also another option, and I prefer this option actually in very small masses, and that's active surveillance. So in a mass that's less than 3 centimeters, the risk of that spreading is very low, and so we can watch that pretty safely and see what it does over time to help us gauge if this is a concerning mass or not. I always tell my patients this, the problem with biopsy is that it's a procedure. It's a real procedure. It has risks of complications associated with it that are not insignificant. Things like bleeding, pneumothorax. These are real deal complications. Rare, yes, but still there. And then about 10 to 15% of the time, we put them through all that and we still don't have a diagnosis. We get a non-diagnostic result. And so it wasn't really helpful. And indeed, the negative predictive value for biopsies is around 70%. And that's not great if we're trying to tell somebody whether we feel confident that we're going to watch this and it's not cancer or it's benign. There is also a theoretical risk of seeding the tract that you're biopsying. It's super rare, but it is described and is a risk as well to poking these renal masses. What about active surveillance? Well, there was a nice study that was done in Fox Chase that included 154 patients on active surveillance, followed them for 2 years. About half of them, 45%, underwent treatment. And they were actually pretty good at deciding who those patients needing treatment were, because about 84% of them were malignant that they got treatment. It's interesting to note that of the ones that got treated that were cancer, the vast majority of those, as you'd predict, are clear cell renal cell carcinoma. It's also worth noting, though, that just because somebody gets treatment on active surveillance, it doesn't always mean that they're dealing with a malignancy. And in fact, this is another study that looked at 371 patients on active surveillance over a shorter period of 12 months, had a much lower rate of treatment. But what they found was that about half of those patients, yes, they had a reason to get treated. They were showing concerning signs of increased growth rate and stage progression. But also, half of them just did it because they were stressed out and needed to get this thing taken out in order to help them make them feel better. And what are the repercussions of all this? Well, we know that we're taking out more masses. And as we take out more masses, the percentage of benign masses that we're taking out has been pretty steady, if not a little bit increased over time, which you'd expect. If we don't know what these are and we're cutting them out, especially for things like stress from a patient perspective, there's really like a 30% chance that we're cutting out a benign tumor that didn't need to get treated. That risk is even higher in this real small masses, like the less than 1 centimeter masses, and it can be as high as 40%. And ultimately, the problem here is the imaging. We don't have a good way of understanding what's malignant and what's benign. And you can see the sensitivity and specificity here for all the imaging modalities we have at our disposal today. CT is great for catching them. It has a high sensitivity. And so you see a renal mass, it's probably a renal mass. We have a good way of detecting them. However, a negative scan doesn't necessarily mean, the positive scan doesn't necessarily mean that it's positive. So our specificity is low. MRI is a little bit better with sensitivity, but about the same on that specificity level. And then with PET scan, I actually never recommend getting a PET scan for these patients for FDG PET because it's pretty poor, as you can see, in both sensitivity and specificity. So it doesn't give us a whole lot of information that's helpful in renal masses. So that's where CA9 imaging comes in. So what is carbonic anhydrase 9? Well, it's a transmembrane glycoprotein that's involved in oxygen sensing pathways, and it's a regulator for the pH, this acidity outside and inside the cell. When you create an acidic outside of the cell, you make it very feasible to spread and grow. When you have an alkalytic inside of the cell, you get in a good environment to keep proliferating. So CA9 helps regulate that, and it's usually induced by hypoxia. However, when you get a mutation in the VHL tumor suppressant gene, it is upregulated even when you don't have hypoxia present. And interestingly, it's expressed in 95% of clear cell renal cell carcinomas and not expressed in normal kidney tissue. So it makes it a really interesting marker for imaging. And it's actually old news. It's something that's been around since the mid-'80s when they identified it, when they found it in a murine mouse model. They found this monoclonal antibody, and they detected it in 46 out of 47 RCC mice in the primary lesion, and almost all, 7 out of 8, of metastatic disease in these mice. So it had a lot of promise early on. However, when they started to look at it as a treatment, it didn't show much promise, and so it lost a lot of its fuel behind it and interest in it. However, girentuximab is a little bit different in that it uses this kappa light chain chimeric monoclonal antibody, and it pairs it with really the perfect partner for an imaging modality, and that's zirconium. Why is it a perfect partner? Well, the antibody is actually taken up into the cell and lives within the cell, which helps it live and stick around for a long period of time. The zirconium also has a pretty long half-life of 3.5 days. And so you get this nice marriage of something that's going to stick around and stay around to be able to capture an image while all the noise washes away. And I'll show you what I mean by that. So if you give this and you watch it over time, you can see there's a lot of noise, background noise in that first image. However, the longer you wait, the more it sticks around in that clear cell renal cell carcinoma cancer cell, and everything else washes away, which makes it at 168 hours pretty obvious to see. And that's how you read these. It's as simple as that, which is what I really like about the scan. You know, it's really simple. Anybody can read it. I can read this to you, but it's really straightforward. If you see it, that's positive. So it has to have radioactivity that's clearly visible, and it needs to be clearly greater than normal tissue. And given that signal to noise background ratio, it is really, really nice to be able to pinpoint them. And I'll show you some examples here. So this is a small right renal mass, obvious, right? There's no mistaking this. It's a really hot, bright lesion in the kidney. That's a clear cell renal cell carcinoma that they took out, and it was clinical T1A disease. This is that same patient, and I show it to you because you can see what the CT scan looked like, and you get the sense of, okay, this is what an indeterminate renal mass looks like. You know, I wouldn't be able to tell you whether this is clear cell renal cell carcinoma or potentially even like a complex cystic mass or a simple cyst that has some hemorrhagic components. When you get the CA9 imaging, it really makes it clear and obvious. So early phase 1 trials of this girentuximab imaging modality were pretty promising. The phase 1 Zircon trial was looking at 10 patients, and it differentiated 6 out of 10 with those clear cell renal cell carcinoma, and it was really well tolerated. There was another phase 1/2 trial, the Zircon trial. This was a little bit different. It had 16 patients with renal masses and then 14 patients who had suspected recurrence or metastatic disease. And interestingly, it found all the PET positive primary lesions, all the PET positive primary lesions were clear cell renal cell carcinoma, which was fantastic. And there was really no lesion progression seen in those PET negative masses. So pretty convincing evidence and use of this in recurrence, monitoring for recurrence, and in metastatic disease. Interestingly enough, too, it also led to a major change in management in 36% of those patients and avoided a repeat biopsy in 21% of patients, which is really the goal here. There's another study, the IMPACT study, that looked at metastatic disease, just seeing how much we pick up with girentuximab compared to regular PET imaging or CT. And it pick up a lot more tumors. So 70% of lesions were visualized on the girentuximab, while only 59% were seen on PET, FDG PET, and then 56% on CT. Now, importantly, these aren't confirmed with histology, so we don't know whether these are real that it's picking up, but it's certainly seeing more than what our conventional imaging of what we have today. And this is what these metastatic cases look like. Some of these we probably catch on CT, like that mediastinal lymph node, I'd probably see that on CT. The lung lesion, probably certainly. But these bone lesions or the mesenteric lymph nodes, soft tissue masses, these are things that I think are really a potential exciting use for CA9 and might give us a lot more information than what our current imaging has to offer. So that brings us to the Zircon study, which is really the highest level evidence we have in using girentuximab. It was a multi-center international study that occurred between 2019 and 2022. And it included patients who had an indeterminate renal mass that was relatively small, less than 7 centimeters, on CT or MRI, and was suspicious for clear cell RCC. Importantly, those patients were then scheduled for surgery, regardless of what these images showed. The endpoint they were looking at was sensitivity and specificity of girentuximab, and their key secondary endpoints were looking at those same endpoints, but in the smaller mass subgroup, so any mass less than or equal to 4 centimeters. And what they did is they gave the girentuximab on day 0. They then waited 5 days, plus or minus 2, to get the imaging. And then within 90 days of that imaging, they had the mass removed so they could see with the highest level of evidence whether it was clear cell renal cell carcinoma or not. So they screened 371 patients, 332 were enrolled, 300 were dosed. There were 284 in the primary analysis. You can see the breakdown in histology in these patients was as you'd expect. 63% had clear cell renal cell carcinoma, with a lesser percentage having benign lesions like oncocytomas. And you get a pretty representative breakdown of what we see in the malignant renal masses in that cohort. And these are the results of all the patients, pretty promising. And the promising component here is really the specificity. So you can see sensitivity rivals CT here, but the specificity is quite a bit better at 87%, which gives us a positive predictive value of 93%, which is pretty great for detecting clear cell renal cell carcinoma. It's even more interesting when you look at the smaller renal masses. So the specificity here is a little bit better, 89%. So the smaller these masses get, it would seem, the better our imaging gets. When you look at the real small renal masses, and again, it's worth noting this is a small number of patients, 20 patients, but pretty promising, 96% specificity, positive predictive value of 96.7%. So these are the masses we're most worried, like most unknown, unclear of what they are. And if there's a potential that this can really perform better in those small masses, I think it has a lot of promise. You know, interestingly, when you go looking for stuff, you find other stuff that you didn't want to find, as we always do with all these images. And the Zircon trial found that. So we found renal masses, but we also found masses outside of the kidney. And that happened, you know, in a fair number of patients. 14 patients had extrarenal lesions detected. Most of these were in the bone and liver. How this parses out, how reliable it is in detecting that, and whether it's true or not, we still don't know because we don't have histologic correlation with it. But there's a potential here that might dictate management if you're starting to see metastatic disease earlier in the disease process before surgery. It's also worth highlighting that the false positives on this imaging are actually not technically false positives if you're looking for cancer. So the vast majority of these were still cancer. Were still things we would take out. So even if it were positive and wrong, you know, there's only one oncocytoma, and even that oncocytoma had a sarcomatous component. So almost all of the negative or the positive scans that were not clear cell were something we'd be dealing with anyway. What about negative cases? Well, I'll give you a representative of what those negative cases look like. This is an oncocytoma here, and you can see it's the opposite obvious finding. So you have uptake in the kidney surrounding it, but no signal at all on that renal mass there. That's clearly an oncocytoma. And when you look at it under the microscope, you can see why. So that CA9 doesn't stain at all because oncocytomas simply don't stain for the CA9. And so you really get a dark lesion here that is potentially as useful as the bright lesion. Chromophobe RCC, same thing. You see this dark lesion on the right kidney here, pretty obvious to spot, pretty obvious that's not uptaking any of the girentuximab. And when you stain it, sure enough, there's no CA9 immunohistochemical staining there. How was it tolerated in Zircon? Pretty well. Most of the adverse events were consistent with what we see post-surgically. There were very few adverse events that were definitely related to girentuximab, and most of these adverse events were very mild, and only 6% had a grade 3 or higher adverse event. Most of this is like fatigue, nausea, vomiting, things like that. There were no safety signals observed, and this is not news. This is pretty consistent with what we've seen previously with girentuximab in the early phase 1 studies. So in summary, girentuximab is an investigational radiodiagnostic agent for PET imaging to characterize renal masses as clear cell renal cell carcinoma. It targets CA9, which we know is expressed in the vast majority of clear cell renal cell carcinoma cells. It has a high sensitivity and specificity with an emphasis on the specificity, I think, in my opinion, and that positive predictive value in identifying the clear cell renal cell carcinoma. And it has a similarly high sensitivity and specificity and positive predictive value in the smaller renal masses, and potentially on lower number of patient data might do even a little bit better in those small masses. It uses a differentiated monoclonal antibody approach, lending a relatively longer circulation and retention that allows for that clear imaging of renal masses. And it might guide clinical decision making and management of clear cell RCC. I think it probably will in a lot of cases. It may also offer potential for more accurate staging and also monitoring of disease after surgery in the recurrence and restaging setting. So thanks so much. It's a pleasure to talk with you all today, and I hope it's been helpful.
Thank you, Dr. Joyce. We appreciate the information. As we have pre-recorded this webinar, I'd like to note that we do welcome questions, and those can be submitted at physician.education@telixpharma.com. Also, we want to thank Dr. Joyce for his presentation regarding the foundational science of this new advanced imaging. Also like to thank Dr. Sohi for his presentation on PSMA PET-CT and prostate cancer. And finally, a great thanks to the AUA for the opportunity to present this information. So with that, we thank you, and we'll see you on the next one. Thank you.